Hi, have you ever wondered what a chiropractic X-ray analysis might look like? My name is Dr. Quartell from Quartell Chiropractic, and I'm going to go over today how we look at and analyze X-rays from a chiropractic perspective. This is different from our analysis from a pathological perspective. We're not going to be covering today fractures, tumors, pathology, or other findings that we might report on from a disease standpoint. This is more from a chiropractic perspective. So initially what we're going to look for are the type of films that we take. Most of the time we're taking films where we're going to look at the neck and the upper part of the back as well as the lower part of the back, and we take films from the front and from the side. We're going to start today by looking at a side picture in the neck, and this is a picture of a patient, and we can see the back of the head here. We can see the angle of the jaw. We can see the back of the neck and the front of the neck. And there are a couple of things on this film that we can see right away that I'm able to point out and observe. The first is there's a loss of normal curve, or what we would call a typical cervical curve. And ideally, we would like to see a curve that arches toward the front. We can see that there's a loss of normal curve. There's a near straightening or a complete straightening of the curve. Sometimes if we see the curve going the wrong way, we call that a kyphosis. The normal curve that we see here is a lordosis. We don't see the lordosis here. We see a straightening of the curve. The vernacular is maybe a military neck or a loss of normal cervical curve. And what we can also see on here is a change in the health of the disc. So we might grade the disc degenerative change on various different levels. We will compare it to normal. We have charts all over the office that show us what normal and abnormal curves are. And here we can see a loss of normal curve, but we can also see a change in the disc. So ideally, when we look at the vertebra, we can number the vertebrae as 1, 2, 3, 4, 5, 6, 7 cervical. Here's the first thoracic. Here's the second thoracic. This vertebra here is such a large bone on the back as compared to the positioning of the other vertebra above and below. This one that's sticking out, this is the vertebral prominens. It's that first vertebra that we can really feel in the upper part of the back and the neck. On her, it's the 7th cervical vertebra. Some people, it's the first thoracic. But when we look at the vertebra here, we ideally should see all of the vertebra relatively have the same width and shaping of the disc. If we see here, particularly between these two vertebrae, so if we count down again, here's our second, third, fourth, between the 5th and 6th cervical vertebra, we can see that there's a tremendous change in the width of the disc. I can also see the bone is shaped a bit differently from here and here as compared to the nice squaring of the bones above and below. And this we would grade as some degenerative disc disease. If we were to grade it on a scale, we would probably call it a phase 2 degenerative disc disease. And it does become a little pixelated in this large, but you can see how the width of these discs here are much greater than this here. This is also going to correspond to a decrease in foraminal opening, or the area where the nerve exits. We can see here on a model, ideally we should have a nice opening where the nerve exits, and as there's compression, movement, or even maybe some bulging of the disc, we're going to see a decrease in the nerve space there. When there's a decrease in the spacing of the bone, it just inherently makes it more easily compressed. This will then also create problems above and below. When there's a loss of normal curvature here, the spine is then going to transmit force into the upper back, and where any sort of a misalignment might exist, we can see on this film here, there's not a tremendous amount of side-to-side bending. There's no real evidence of scoliosis here. When we drop a plumb line that comes straight down through the upper part of the neck and the back here, it becomes more observable. So here we can see that the line is bisecting the upper part of the neck through here. We can see it's bisecting the vertebral, but then and through here, this, I'm going to make it a lot larger. You can see that the bone here, this third cervical vertebra here, way off to the side in there. And then as we make the spine a little bit larger again, we can see that the upper thoracic spine is curving off to the side. In addition, the spinous processes, right, the parts of the bone that stick out to the back, are rotated from one side to the other. So we don't want to see a lot of rotation one way or the other, and this will lead to additional nerve compression, irritation. And what we can see here is there's a lot of rotation up on top. And there's even some potential evidence of maybe a cervical rib through there that's going to cause some congestion. We can also see an asymmetry in the rib cage through here. When we look for rib cage symmetry, we're looking to see how well the body is able to support the shoulder girdles. Sometimes if we make the film toggle back and forth, you can see that there's a narrowing on the right side and a widening on the left when we compare one side to the other, and this is due to the collapsing of the rib cage and the rotation through there. And this asymmetry leads to an additional workload in the lower back because everything below it has to support it. When we look at the lower back here, we can see here's the lumbar spine from the side. Now, mind you, this is a TV that we're using. It's not an actual screen that we use to diagnose off film, so it's a little grainy, but we can see what we need to see. And on this film, we can see that here's the sacrum, here's the tush down here, the belly button is here. Here's the fifth lumbar, the fourth, the third, the second, the first lumbar, the 12th thoracic, the lower part of the rib. And we're looking at the body from the side up to where the lower part of the chest is, all the way down to the buttocks. And this curvature here, where there's an increase in normal curvature, if we look at the center part of this third lumbar vertebra, we can see that it passes through the belly of the sacrum. Ideally, I would like to see that third lumbar vertebra out in front here. That's a general guide for where the positioning of the spine should be when we see a lumbar curvature. And many times we'll see clinically an increase in lumbar curvature in an effort to offset a loss of normal cervical curve. So if I have a loss of curve here, my neck has become straightened, I'm going to now look at everybody's shoes all day long. I might take my lower back, tilt it back to try to bring the eyes upright and level. And the body has a tremendous desire to continuously keep the eyes upright and level. And if they're forward this way, I'm then going to move this way. And it gives you, even if I'm slender, it's going to give me the appearance of a belly here because I'm walking around like this all day long with a slumping posture. You've seen this guy in the grocery store, right? So this is not the kind of guy we want to be. We want to be more upright and posturally correct. Additionally, another problem or challenge that this patient demonstrates with is what we call facet tropism. When the spine develops, sometimes there's a development change or a development anomaly that creates an unleveling or an asymmetry. Ideally, my hands should be the same size, my ears should be the same size, structures on both sides should be the same. In this patient, we see a condition, I see it in about 5 or 8% of patients. I don't know how many patients it actually, or people it actually occurs in, because I generally only take x-rays of people with lower back conditions. But about 5 to 8% of the time with people with lower back conditions, we see a facet tropism. And what we're going to look at here is a change in the facets, or a change in the symmetry in side to side. Now on this film, you might be able to see, I don't know how well you can see it, but you can see this structure here looks different. There's a degree of asymmetry here. There's a joint space here that I can see. I can't see it here on this left side. And this creates an overworking or a burdening of the lower back between the fifth lumbar and the sacrum. As the body is walking, the pelvis likes to swing from side to side, like the hips like to swing from side to side. That side to side motion is coupled between the fifth lumbar and the sacrum, and if those joints are not symmetrical, that load then becomes transferred to the sacroiliac joints. And we can even see, if we make this a little bit larger here and I outline it, here's the sacrum on the right side, and then here's the sacrum on the left side. And you can see that here's the middle, you can see there's a bit of an asymmetry in the shaping of the sacrum as well. And this is creating some arthritic change down through the belly and the body of the sacroiliac joint. This is a patient, she's in her mid-30s, and she's already developing some arthritic change through that area. We can also see a little bit of a sloping of the curve off to the side. So all this together leads to an increase in joint load. In other words, if we have an increase in load through the neck, it's then going to change the way that we're moving our arms, and then I'm compensating the way I'm moving my arms. I'm going to move my torso this way, and it propagates through the whole body with an increase in load bit by bit. One day, 1 hour, 1 minute of this is not enough. 1 week, 1 month, 1 year, 1 decade leads to an increase in level of problem over time. And this is why we look at X-ray. Just a couple of other things about the X-ray that we note. The first thing that I do look at is I look for if there's any pathology, if there's a tumor, if there's a fracture, there's an infection, if there's any sort of evidence of calcification of the arteries, if there's an evidence of any sort of aneurysm through the arteries. We can see this evidence on our films, which is why we take films in the office before we treat many times. Additionally, when we look at our films, if you're in the medical field, you'll notice these films are backward, right? So we see the right side on the right side here, the right side on the right side here. Typically in medicine, we look at films as if we're looking from the front, but I work from the back. So I put the films up from the back so I can see what it is that I'm looking at. We can also create a postural, not a postural, but an X-ray view here where we can look at the film from top to bottom, and we can see the orientation of the head as it relates to the sacrum. And we can also see the orientation of the cervical curve as it relates to the lower back and the lumbar. Over time, we might see changes in X-ray occur with treatment, especially if we're looking for curve correction. In our office, we're not looking for that much of a degree of correction. We're typically looking for enough of a correction where the body's moving and functioning and you're feeling well. Sometimes patients want to get to that next level. We found clinically, we don't have to make the body ideal positioning. We just have to make it functionally enough so that you can do what you want to do through your life. I hope this gives you a good background on what we look for in our X-ray and gives you an understanding of maybe your understanding your own films when you see them. Remember, at Quartell Chiropractic, we do take X-rays right on site, and we can always share your X-rays with you. A lot of patients travel, so we give you your X-rays. You can actually take them on your phone with you. If you ever have any need, don't hesitate to call. We're always here willing to listen.